Good afternoon, everyone, and welcome to Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo, brought to you by Bevel, Texas, and CSTAT. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the Bevel, Texas providers, please make sure that you identify yourselves during this session, or if you're joining via phone, please email your phone number and name to beveltx@ithaca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow for others to speak up. Or if you'd prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or our discussions. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the Shout Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 Walmart gift card. Additionally, this helps us get valuable feedback from you about how we can improve these sessions. Our didactic today is on what to do when things go wrong, complex buprenorphine starts, and will be presented by Dr. Nicholaus Christian. Following that, we will discuss a case presented by David Markson. We'll start with introductions, followed by didactics, Bevel program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insights in today's conversations. And with that, we will begin with some introductions. Dr. Christian.
Yes, hello everyone. I'm Dr. Nick Christian. I did residency in Austin, Texas, was a part of the B team in the early days. And since I've done an addiction medicine fellowship, and I'm currently a staff clinician at NIDA, their Intramural Research Program in Baltimore.
Thank you so much, Dr. Christian. And I would like to welcome you as a hub member, and he's joining our hub. So thank you so much. Dr. Ramesh?
Hey everyone, I'm Jan Ramesh. I'm a hospitalist at Del Seaton Medical Center. Good to see you all.
Thank you so much. Alana?
Good afternoon, everyone. My name is Alana Bolton. I'm a program manager at Dell Medical School and the director of Shout Texas. Thanks so much for being here with us today.
Thank you. David Markson?
Yes, hello. Thank you for having me. I am David Markson. I'm an RSPS, and I've been enjoying these Shout Be Well Texas sessions.
Thank you so much for joining us today. Julie Parrish.
Hi everyone, Julie Parrish, Echo Program Manager here at Be Well Texas. Thanks so much for being here today.
Thank you for joining us. Andrea Hebler.
Hello everyone, my name is Andrea Hebler and I am a program coordinator with CSTAT. Welcome everybody.
Thank you. And Jasmine Vidal.
Hello everyone, my name is Jasmine Vidal. I'm a program coordinator here at CSTAT. Thank you for joining today.
Thank you. And with that, we will move on to our didactics. Nick, whenever you're ready, you can take it away.
Awesome. Can everyone see my slides okay?
Yes.
Perfect. We'll get started today. I was asked to present on complicated buprenorphine starts, and I kind of morphed it into what to do when things go wrong. And so we will talk about complicated buprenorphine starts, but we will certainly talk about even more than that. Just wanted to share, I don't have anything to disclose But not only do the views and opinions expressed here not reflect UT Health San Antonio, they also don't reflect NIDA, now that I'm a part of their organization. And I wanted to start by, I was just thinking through what are medical crises, especially for me as an addiction medicine physician. What is a crisis for my patients? And I think if there are other clinicians in the room or people in healthcare settings, you can relate to crises that occur with patients. Things like your patient's suicidal. They're in acute shock for X, Y, or Z reason. And so I was reflecting on the definition of crisis, and these are all Webster's definitions. It can be a time of intense difficulty, trouble, or danger. In the case of the medical realm, this is interesting. It can be the turning point of a disease when an important change has taken place, indicating that either the patient can recover or head towards death, or it can be a time when a difficult or important decision has to be made. And so for me, reflecting on the addiction medicine field, our real crisis that we are most worried about always is often precipitated opioid withdrawal. And to me, I hope that by the end of this talk, everyone has the sense that, you know what, precipitated opioid withdrawal, it's not it may be intense difficulty or trouble or danger, but it's certainly not a turning point that could head towards death. So it's certainly not the second definition. I hope everyone feels confident that it's just a time when we have to make some important decisions with our patients and help guide our patients towards health in these critical situations. And so I wanted to start, I'm curious to hear how many people have seen precipitated opioid withdrawal. And if you're able to, you can either unmute or raise your hand. Thank you, Sonia. Or feel free to chat in the chat box. I see a hand up also from Jessica, Zach. So we've got quite a few people who have seen precipitated opioid withdrawal. David, thank you. Yeah, for those of you that have seen it, you know it when you've seen it. And so my hope is that after this talk, we'll define precipitated opioid withdrawal. We'll have some strategies to assist patients in precipitated opioid withdrawal. And somehow in my 1-year clinical addiction medicine fellowship, I saw precipitated withdrawal 4 times, which it's apparently very rare to even see once in our addiction medicine program. So it was a coincidence. One of those cases I wrote up in this case report. You'll get these citations if you're interested in reading more about it. In this particular case, we ended up using ketamine for the patient, and this was in a hospitalized patient. And so I'm happy to discuss more about this case offline. I'm not going to focus mainly on that. But I wanted to provide everyone who hasn't seen precipitated opioid withdrawal with just the foundations of why it happens. And so to begin with, I think everyone knows that fentanyl is what we call a full agonist. And there's this whole paradigm that's starting to shift away from agonist, full agonist, partial agonist, and start to use these terms high intrinsic efficacy, meaning that when fentanyl binds the mu opioid receptor, the metaphor that I use to describe with patients is it's like a dimmer switch. And if you see the orange here, the dimmer switch is turned 100% up from fentanyl in the brain, meaning that it's fully activating our brain. Whereas buprenorphine, it has a bit lower intrinsic efficacy at the mu opioid receptor. So when I describe it to patients, I say, you know, the dimmer switch for buprenorphine isn't up 100%. It's just dimmed a little bit. It's down to about 75%. And so the light isn't quite as bright. And the interesting thing, and the whole reason why precipitated withdrawal can happen is that buprenorphine has such a high affinity for the opioid receptor, meaning that it will bind and kick off anything else that's on the mu opioid receptor that might already be there. So how does this look at the receptor level? It looks like this. If someone already has fentanyl in their system, it's going to be binding the opioid receptor, and you're going to have the dimmer switch turned 100% up. as soon as you give buprenorphine, it's going to knock off the fentanyl from the receptor, turn the dimmer switch down to 75%. And that quick dimming of lights, that's what manifests as precipitated opioid withdrawal. It's that quick withdrawal that occurs after giving someone buprenorphine. If you think about when you're in a theater and the lights are slowly starting to dim before the performance goes on, sometimes you don't even notice for the first little while that the lights are dimming down. And so that is, I liken that to being like when we're doing our low dose initiations, where we're slowly giving a patient a little bit of buprenorphine time and time again. When you're dimming the lights slowly, you don't notice it as quickly. Whereas in precipitated opioid withdrawal, you're turning those lights down really quickly, and it's really noticeable and causes tremendous distress for our patients. And I just quickly wanted to nerd out a little bit on this paper from Greenwald and colleagues. They postulate that there's something going on with the opioids that we put in our systems, and they call it an ALE score. ALE standing for the affinity, the lipophilicity, and the intrinsic efficacy of the opioid exposure. And they believe that that's what determines our opioid balance. So for fentanyl, it doesn't have quite as high affinity, but it has crazy high lipophilicity and also very high intrinsic efficacy. So that gives it a really high ALE score. And then if you quickly give someone buprenorphine, it has a very high affinity, but less lipophilicity and less intrinsic efficacy, which overall means your opioid balance is going to be lower if you give it at that moment. And so that's just another framework to think through. Why is it that buprenorphine can cause precipitated withdrawal? And also, why is it that things like fentanyl have such a higher risk of potentially causing precipitated withdrawal if you're exposed to that, as opposed to things like oxycodone? Oxycodone doesn't have quite as high affinity, not quite as high lipophilicity or even intrinsic efficacy at the receptor as something like fentanyl. And so the ALE score for oxycodone is much lower than what it would be for fentanyl. And so the opioid balance changes because of that. And I'm going to try to keep an eye on the chat, but please feel free, if anyone has questions as I go along, you're welcome to interrupt me. So the clinical definition of precipitated withdrawal is that you have rapid 5-point increase in your COWS score within 2 hours of starting buprenorphine. And this working definition isn't necessarily widely adopted in the field. And if you try to look up precipitated withdrawal, there really aren't all that many studies. Aside from Gail D'Onofrio and Andrew Herring and colleagues, their multi-site emergency department Bupe initiation trial, they tracked 1,200 patients who were started on buprenorphine in the ED. And I'm curious to ask everyone, out of those 1,200 patients, how many do you think had precipitated withdrawal? We've got a guess for 7. Man, someone is in the literature a bit. And how many, any other guesses from others? 50%. All of them. Actually, I was very shocked. And Sonia, you're in the right ballpark. Only 9. That's less than 1% of patients started on buprenorphine in this ED protocol had precipitated withdrawal. That doesn't completely mesh up with my clinical experience, having seen it 4 times now, and I know I haven't seen 1,200 patients yet. So I think there's more to be developed here, but I more so wanted to include this number to let everyone know that if you aren't prescribing buprenorphine right now, don't you worry about precipitated withdrawal. Yes, it's a theoretical risk, but I hope that if it happens, you know that, okay, I just have a game plan for how to help these patients and treat them through it. It's more critical that we're expanding access to this medication for our patients than it is to be fretting about potentially causing this. And we know from some epidemiological studies that it actually is quite rare. So Narcan was not pre-treatment for those patients, John. Their protocol was, if you were included in the study, if your CALS was greater than 4 at admission. If your CALS was greater than 8, they dosed you in the emergency department with Bup 16 milligrams. If your CALS was less than 8, if your CALS was greater than 8, they would dose you in the ED. If it was less than 8, but greater than 4, they would send you home with buprenorphine. And so, yeah, they have data from both the patients who were sent home and the patients that were dosed in the emergency department. The thing that's critical to note, though, is these patients who were started, they were in opioid withdrawal. This is a very confusing chart from this Greenwald lecture as well as their trial, but I'm going to try to demystify it slightly. If you start by looking at this bottom label, the agonist withdrawal balance, all that means is that numbers in the left that are negative, that means these are people who are in withdrawal. So the more negative, the more withdrawal you're in. Positive, meaning you have a positive agonist balance. The more positive, meaning you may have just used fentanyl or something along those lines. What we see in this chart is that the more withdrawal you are in, it doesn't matter what dose you are given, you're probably going to benefit from buprenorphine. Where things get interesting is when you're not, so it should be clearly stated, the patients in the ED study, everyone was in this negative withdrawal balance, which is important. That's what a standard protocol is. We wait for our patients to show objective signs of withdrawal, then we start them on a standard initiation. What's interesting is for patients who might not be in as severe withdrawal in this region, they suspect that giving buprenorphine doses between 1 milligram and 8 milligram actually might be just the right doses that could precipitate someone in withdrawal. Whereas giving doses less than 1 milligram in this micro-dosing fashion, that won't precipitate withdrawal because of the amount of the receptors that are still bound to the full agonist. And if you were to overcome all of those receptors with large amounts of buprenorphine, greater than 16 milligrams, what we call this macro dosing protocol, you also should have theoretically less risk of precipitated withdrawal. So the whole goal in avoiding precipitated withdrawal is to achieve a positive agonist to withdrawal balance. And it's possible that if someone's not in significant withdrawal, that doses between 1 and 8 milligram are actually higher, at the highest risk of potentially precipitating someone, whereas doses less than 1 milligram and greater than 16 milligrams are theoretically better if someone's not in significant withdrawal. All this to say, our first line should be waiting for patients to be in significant withdrawal prior to starting them on buprenorphine. However, you're going to see that as you get more comfortable with the medication, you're going to start to push that because there are some patients that really need to be started as soon as possible. And just know that those doses between 1 and 8, if you're not in serious withdrawal, those can be potentially higher risk for precipitating withdrawal in our patients. Any questions about that? I know that this is a very complicated chart and there's even more to dive into in this. So if you have time, meditate on this for a couple of hours. And I think that you'll glean quite a bit from it. A question that I faced in several of my cases of precipitated withdrawal was, what do we do now? And how do you think through what the next best step is? And I personally found that a lot of it depends on how much buprenorphine has already been given to our patient. So if you look at this chart, this is the percent mu opioid receptor availability, and this is the amount, the buprenorphine dose. So as you can see, if you give 32 milligrams of buprenorphine, there's very little mu opioid receptor left that can be bound. And so if you give 16 milligrams even, there's already less than 10% of the patient's mu opioid receptors that are available to bind. Saying this in a different way, if you give 16 milligrams of buprenorphine, you know that 90% of their receptors are going to be bound by buprenorphine. What does this mean in terms of precipitated withdrawal? Well, I think that if you have given someone less than 16 milligrams of buprenorphine, you actually might be able to theoretically get them out of precipitated withdrawal by giving them more full agonist. I don't recommend that, but it is an option to patients. Typically, if you're giving them more than 16 milligrams, you have very little headroom to give them full agonist that's going to help them. And so I use that to counsel patients that giving you more full agonist probably isn't going to help you. The only direction we have to go now is to give you a lot more buprenorphine, which sounds like a contradiction, but because buprenorphine does provide our partial opioid agonism, or it at least has some intrinsic efficacy at the mu opioid receptor, you're probably going to get more bang for your buck just giving more buprenorphine as opposed to giving a high dose full agonist. So in my mind, that's what I'm thinking about when I see our patients in precipitated withdrawal. First thought, how much bup have they given? Do they have any opioid headroom to potentially give them things, high potency opioids such as fentanyl or hydromorphone? But the first step that everyone should think through is, how can I make my patient feel better? For those of you that have seen precipitated opioid withdrawal, I think you know that it is possibly the worst human suffering you can see someone experience in front of your eyes. Things are coming out of every single orifice. There's tearing, vomiting, people are writhing on the floor. It is incredibly uncomfortable. And so the first thing should be, you're at bedside and you're letting the patient know that you're there for them. And you're also giving them adjuvant medications to help comfort them. Things like per the California Bridge protocol, they have this great framework for treating precipitated withdrawal. Of course, you're acting quickly. They recommend just giving another 16 milligrams of buprenorphine right away. And that's because in their protocol, they're already giving 16 milligrams of bup up front in most instances. And so you're giving the adjuvants like lorazepam, 2 milligrams. I'm not a huge fan of giving antipsychotics, but certainly giving a lot of clonidine up front. You can consider gabapentinoids. I also don't have as much experience with DT or D3 agonists, but you're getting these medications in the patient's system as soon as possible, as well as trying to get buprenorphine into their system as quickly as possible. There are some patients that will not agree to getting more buprenorphine. And that's understandable. They just received buprenorphine and it made them feel like garbage. Why should I trust you, doctor, to give me more buprenorphine? It's paradoxical, and that's how I explain it to patients. More buprenorphine is going to make you feel better in the long run. If you don't want it now, let's get you things like the lorazepam, the clonidine. And if giving more buprenorphine doesn't help the patient, I want to let you know that there are other things that can help. Things like ketamine, giving 0.3 mg per kg IV slow push, especially for my colleagues who are practicing in the emergency department. They are so ketamine happy. It's very easy to dose it in the ED. It's not as easy to dose it when a patient's on a general medical floor. In both the cases that I've started patients on ketamine in the hospital, they had to be transferred into the intensive care unit. I do also want to quickly note that if your patient's not accepting buprenorphine, you can try opioid agonists, but it's going to require a huge amount of opioids. Things like, per the California Bridge protocol, fentanyl 200 micrograms IV every 10 minutes. And sometimes patients need more than 2,000 micrograms. I did have one patient who received 8 milligrams of bup, and we were able to make him feel more comfortable with hydromorphone. We used doses of 5 milligrams IV every 15 minutes, and I believe they received over 20 milligrams in an hour. They started to feel more comfortable. We were able to stabilize them on a dose of full agonist for a couple of days, and then do a low dose transition to buprenorphine while they were in the hospital. And they ended up doing the low dose transition without any problems. And they were on buprenorphine at discharge. So there's a lot of different things you can do with this. I think that I'm at my 20-minute mark. So I just quickly wanted to wrap up by describing ketamine and why we think it works. It's an NMDA receptor antagonist. At low doses, it's an analgesic. At high doses, it's a dissociative. The doses that we use, the 0.3 mg per kg, that's actually a lot lower than the dissociative dose. But we think that it works by recycling mu opioid receptors. And so it helps bring more mu opioid receptors to the surface so that the buprenorphine can bind to those receptors and provide a higher opioid, total opioid signaling and opioid balance that's occurring. And so that's why we think it works. When you're giving ketamine, you should also be giving more buprenorphine so that you have more of this partial agonist effect. The dose that we used in the case report that I described was 0.3 mg per kg. We gave that over 15 minutes, and then we gave another 0.3 mg per kg over an hour. And the patient, after that was ran, felt much better. The biggest thing I want to emphasize is that this is precipitated opioid withdrawal is a crisis for addiction providers. It's also a crisis for our patients. But I just want everyone to know that it's just a time where difficult decisions have to be made. And the most important thing is to be there for our patients. It's incredibly isolating for patients when they feel this terrible. And so in all of the cases that I've had, I made sure that I was at bedside with them through the beginning until they feel better. And I think that that goes a long way for our patients when they're in these critical situations. And so here are my references. And I'm not sure if we have time for questions, Priya. I'm happy to take them. If not, I'm also happy to go into our case for today.
Thank you so much, Dr. Christian, for this wonderful presentation. And I do believe we have a few minutes that we could take a few questions, because I know the chat has been firing up through the presentation. So I will open up the floor for any comments anybody has to share or any questions.
James, thank you for sharing that. I do think that those doses, the between 1 and 8 milligram, are the kind of dangerous doses for our patients that you're on the fence. I can't tell if their withdrawal is really that severe or not. Like I said, if they're in severe withdrawal, the dose probably doesn't matter. But I appreciate you sharing this study with us that furthermore supports my clinical experiences and our clinical experiences.
Can you talk a little bit about outpatient at all, or are you just familiar with inpatient?
Sure. So I actually had the opportunity this past year to do a lot of outreach, where we had a mobile van and we would go out and talk to patients who were interested in harm reduction materials, and I would start them on buprenorphine in the field. And I didn't have a case of precipitated withdrawal, but I did greatly counsel patients on the risks of fentanyl. And anymore, if patients are unable to start on dose, to discontinue their use for greater than 24 hours, I get a little nervous. And so there's a protocol that is rolling out of Philadelphia, and I'm happy to send the protocol out. But I often give patients the option of, you either have to stop for a long period of time and then start on 16 milligrams right away, or if you can't stop your use for that long, there's a protocol where you dose someone every 2 hours, and you start, I believe it's at like 0.5 milligrams every 2 hours for 4 doses, 1 milligram every 2 hours for 2 doses, and then you do 4 milligrams every 2 hours for 2 doses. And then you can just start them on 8 milligrams on the next day. And that's shown to be effective for patients who are on fentanyl. Unfortunately, they haven't published findings from that protocol, but anecdotally, this is a population with a high amounts of fentanyl, high amounts of xylazine in their drug supply, and they state that that protocol works for them. So Sonia, I counsel patients on those two options in the outpatient setting, either starting them on 16 milligrams at least right away, and if they take the 16 milligrams and don't feel better, that they have enough supply with them to take an additional 8 to 16 milligrams up to 32 milligrams on day one. So I'm pretty liberal with how much Bupe we send patients on when we're initiating, because it's quite possible if they precipitate, they might need more on the first day than just that 16 milligrams. Any other questions around that? Happy to clarify anything.
Well, thank you so much. And we'll keep the chat going. Please feel free to keep putting your questions and comments there. And we will move on to the next part of our session. Julio, if you could please bring up the announcements. Thank you so much. The Center for Substance Use Training and Telementoring provides high-quality education in best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals for people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide. You have to text by midnight tonight to claim your CME credits for this session. Please text attend 1009-5083 to 844-502-1338. Next slide. Please save the date. Texas Substance Use Symposium is happening in Austin next year on Feb 29th and March 1st. Registration will be opening soon. Next slide. Please, this is a reminder, our December Shout Echo session will be canceled due to the holidays. Please join us on our next Echo session on Thursday, January 18th, 2024. Next slide. In the meanwhile, please make sure to join our other sessions happening in December. We have the TextRx happening on Tuesday, December 19th. We also have harm reduction and public safety echoes happening in December. So please do join us. For more information, you can visit our website at cstat.utisca.edu. And we'll now move on to our case presentation. Julio, if you could please share the case form, and David, you can take it away whenever you're ready.
Thank you very much, Shreya. Before I get started, first of all, I want to introduce a friend of mine who's here with us today also. His name is Ron Deeg. Ron and I have kind of a similar experience with the person that we'll be presenting the case study. Also, I want to make a correction. I was one of the people who raised my hand when Nicholaus asked who has experienced precipitated opioid withdrawal or observed it. I have neither experienced it nor observed it. I've experienced and observed opioid withdrawal and also withdrawal from buprenorphine and Suboxone and so on. So with the record set straight, I'm going to be talking to you today about a gentleman, and I'm going to call him Fred, but let me make it perfectly clear. His name is not Fred. It's just a name I like to use, as a placeholder. So, and the way this all came about was on September 21st at one of these, Shout Texas Echo series programs. The discussion was about methadone and alcohol, concurrent methadone and alcohol use disorders. And I had just been talking to this gentleman, and I asked a question, and then Alana Bolton contacted me and said, would you like to present a case study? So I guess the lesson is from this, if you ask a question, you might get asked to present a case study, but I'm happy to do it. So this gentleman, this is a little bit of an awkward presentation because I'm an RSPS, but I am not his RSPS. And my buddy Ron, who's with us, is a therapist, but not Fred's therapist. So we are all in the same 12-step program, and haven't seen Fred in quite a while, probably since back in September. But he contacted me, he called me, and he explained his situation, that he is a heroin addict who has been on methadone for about 4 years. And he's also got this concurrent alcohol use disorder. And he would come into our 12-step meetings. And I'm going to be kind of circumspect about the 12-step group I'm in, because I'm not an authorized representative of the group. So I don't need to name the fellowship. You can probably figure out what it is, but I'm going to be careful about that. But, you know, he was trying to stop drinking, or at least mitigate his drinking. And he didn't have much success at first. And then he was able to stop for about 30 days. And then he returned to it. He tried to get into, this is the crux of the matter, he tried to get into an alcohol treatment program, and he was denied. He was told, you can't be in the program if you're on methadone. And that was the question that I asked on September 21st. And one of the replies I got from, I believe it was a doctor who was attending, was that that's wrong. But unfortunately, it happens all the time. And that the gentleman, the individual, Fred, does have the option of filing an Americans with Disabilities Act complaint. I'm not sure that he's inclined to take it to such legal extremes. I know, or measures. I know that he's concerned about his personal freedom, that he has some entanglement with the legal system, and he could end up in prison if he goes back to using heroin. So anyway, so he talked to his methadone clinic doctor about the alcohol use disorder and how he was trying to mitigate and so on. And the methadone clinic doctor, I think perhaps wisely and in a merciful way, increased his methadone dose from 79 to 84 milligrams to give him some comfort as he went through the alcohol withdrawal cravings. So the real questions I have, these are the questions that Fred had for me, and I turn them over to you. What treatment options are available for this person? We know he can file an Americans with Disabilities Act complaint and try and get into a 28-day program or whatever. But other than that, are there any other suggestions to help him in his recovery from his alcohol use disorder? And just to underscore that I don't have any standing here. I am an RSPS, but I'm not his RSPS. That what I can do for him is be supportive as a fellow member of the same 12-step program. Mainly he talked, and mainly I listened. And the obstacles, in addition to me having no professional standing in Fred's case, I'm not certain Fred wants to stop drinking and or using. I know he doesn't want to go to prison, and I know he doesn't want to be in pain. I suspect if he could mitigate his drinking, that might be good enough for him. And I think that's all I've got. Ron, do you have anything else you want to add to that?
Well, I would only say that he attended our meetings fairly regularly for a while, even though he was still drinking, and was honest about that. And he was able, like I think you said, David, that he was able to maintain some degree of sobriety from alcohol for some period of time after coming for a while to our meetings. And I saw clients at a doctor's office who prescribed buprenorphine and Suboxone. And it's quite a bit of a progress in my mind from methadone with the ease of administration and the different way that's going about. But yeah, harm reduction is a big thing. You'll find some people saying sobriety is not taking methadone, but it certainly is progress. And this guy's really intelligent and smart, and although we've lost contact with him, I think he was serious about his methadone, that's for sure. Thank you.
Thanks, Ron. Yeah, and just to add to that, he struggled for quite a while, but as Ron said, he showed up every day, and he had kind of a hangdog, I'm a suffering, but then he did get total abstinence, I believe, from alcohol for about 30 days. And then my understanding is that he's back on drinking and the methadone, never stopped the methadone. So does anyone have any suggestions?
Thank you so much, David, for sharing your case. Yes, Nick.
Yeah, David and Ron, thank you for sharing this case. It is a very common clinical situation that we find. And it's frustrating how many, even nursing facilities, like patients being discharged from the hospital on methadone, that they won't even accept some patients who are on medications for opioid use disorder. And we see clearly that it is a violation of the Americans with Disabilities Act. And I think that we're starting to see some litigation against some of these facilities. So hopefully this will start to scare places into accepting patients and figuring out protocols for patients on methadone. There are a lot of stipulations, like Sonia, I appreciate your comment stating that it's tough for patients to get methadone when in inpatient facilities. There are a lot of barriers. Opioid treatment programs are highly regulated, and it's very rigid and very challenging to try to bend those rules to get our patients the care that they need. But it is possible, and we're seeing this happen. When I was thinking clinically about this individual, I think that there are two things from, well, I guess the first thing, I would love to poll the audience. Does anyone know of any facilities that are doing inpatient detoxes that will accept patients on buprenorphine or methadone?
I know of several for buprenorphine, but I'm in East Texas.
Okay.
We have More Than Rehab. They'll accept patients on Suboxone. It does alcohol detox. And we have Synacor. There's several others, I'm certain, because I looked into it for patients. Methadone, there's some type of regulation that's listed. I've actually viewed it myself with the DEA about methadone in hospital. So when they're, in a hospital setting, inpatient. But maybe those things will change, or they have changed since I worked inpatient, but there was a lot of barriers, even working with a psychiatric specialized pharmacist who would try to get around the law by splitting their dose of methadone. And the patient would not be able to be diagnosed with OUD, where that could have been caught, especially as a primary diagnosis.
I wonder if there must be some clear distinction between inpatient hospital versus inpatient detox programs, I'm guessing. Because in the hospital.
Yes, and they'd have to name it for pain. It would have to be documented that the methadone was split for pain and not used for OUD to get around that. So we could help methadone patients with other mental health and substance related problems.
Great, thank you for sharing. Synacor, I think you said, was one. If anyone is interested in those options, Sonia, feel free to put, if you've done research on this in the facilities that are open to buprenorphine, I think it'd be helpful to make that knowledge known. But aside from that, my mind goes to, there are two things that we can consider tackling, either altering their medication for opioid use disorder, switching them from methadone to buprenorphine, so that they could potentially go into other programs. And the best luck that I've ever had doing a low dose initiation of buprenorphine is with patients on methadone. Especially if they're on doses less than 100 milligrams, between 80 to 100, I feel very comfortable that you can get a patient on even an outpatient protocol where they dose their methadone every day while you're giving them 0.5 milligrams of buprenorphine for day 1 milligram on day 2, and you slowly go up over 7 days. And if anyone's interested in those protocols, please feel free to email me. I'll put my email address in the text box. Furthermore, you could consider switching their MOUD. The other option is there are medications for alcohol use disorder that could be considered. We do have our resident MAUD clinician, Jan, on the call. Jan, do you want to weigh in on your thoughts for MAUD for this patient?
I was just gonna echo, I think what Sonja said. You can't use naltrexone in this patient, which is, my favorite medication for alcohol use disorder. But if the patient doesn't have any kidney issues, then acamprosate might be an option for them. But that was going to be my main contribution to that. I know there's a little bit less data on things like gabapentin and topiramate. I'm not quite sure how those would interact with the methadone treatment, but I think Camprol would be a good initial therapy.
Yeah, this is timely as well. There was just a meta-analysis of a lot of medications for alcohol use disorder, and it looks like the data is looking a little better, that acamprosate is actually might be superior to naltrexone by the numbers. Now, acamprosate, for those that aren't aware, you have to dose it 3 times a day, and so it's a lot of heavy pill burden. And so because of that, we often turn to naltrexone first. For those that aren't aware, naltrexone is an opioid blocker, a full-on antagonist. So if this patient was on methadone and they were to take a dose of naltrexone, they would immediately go into precipitated withdrawal. So they're no longer a candidate for naltrexone. As long as their kidneys are healthy, really, that's the main contraindication to acamprosate, which is kidney disease. And so that would be, I think if your EGFR is less than 60 or less than 30, you'll want to look that up. But if it's less than, if your glomerular filtration rate is low, you shouldn't consider acamprosate. There is some okay evidence that gabapentin can work for these patients, and we use gabapentin all the time in patients who are on buprenorphine or on methadone. It looks like gabapentin is most effective for people who have had alcohol withdrawal in the past. And so if someone has had alcohol withdrawal, gabapentin appears that it helps them through their withdrawal and also is more likely to stabilize them and reduce drinking in the long run than someone who might not have severe alcohol withdrawal but just wants to cut down their drinking. The other interesting thing about acamprosate is in a lot of the studies, you had to have abstinence. So you had to cease using alcohol entirely for a couple of weeks before starting on it. And so we think that it works best in that way, but that's really the only way that it's been studied. So that's another thing to counsel patients on, is that acamprosate is better if you want to maintain abstinence, whereas we know that naltrexone appears to help best in reducing the number of heavy drinking days. But for Fred here, he's not a candidate for naltrexone, so I would consider talking to him about acamprosate or potentially gabapentin. Anyone else have thoughts on the case? It's an interesting one.
Thank you all for your suggestions. I think I'm going to reach out to Fred again. As Ron said, we haven't been in touch with him for a while. I don't think I ever mentioned to him the possibility of the American with Disabilities complaint. I just assumed it was something he wouldn't want to pursue, but that could be wrong. And also that there might be other medications for alcohol use disorder. Sonia, did you have a question or comment?
I was also going to mention, it's more emerging practice. I've been doing it for probably 5 or more years, providing ambulatory detox for patients that are candidates. I see them every single day for the first 3 to 5 days. They cannot have a history of true DTs, which is seizures or delirium, hallucinations. It's case dependent. But I don't know if the patient has insurance or not. So, I have openings in my private practice. If you'd like to provide him my contact information.
Yeah, if you had put it in the chat, I suspect he doesn't have insurance. He was earning a living as a painter. And I think he was like an independent painter. I don't think he was working for a large painting company or anything like that. I'd like to take advantage of the last couple of minutes to just put in a kind of an editorial plug for the value of 12-step programs. And once again, I'm not here as a authorized representative, but it's been enormously helpful to me in my recovery. And I heard a statement at one of these shout echo sessions. It was not the one on September 19th or whatever it was, 21st. It was one more recent than that. It may not have been a Thursday one, but someone who was presenting a case study made the comment, well, she might want to go to a 12-step program, but 12-step programs insist on total abstinence. And I don't think that's a fair or accurate statement. First of all, 12-step programs are different. There's AA, NA, CA, and other A's. So I don't think you can make a blanket statement about that. I think the problem is that the 12-step programs are so decentralized. In fact, there's a tradition in one of them anyway, that says that each group is autonomous, except in matters affecting other groups. So it's very possible that someone would walk into a 12-step group meeting and have their feelings hurt, perhaps very badly. Oh, you're on methadone. Oh, you're not sober. You don't belong here, or something like that. The same thing can happen with the spiritual angle. Oh, you don't believe in God? Well, you'll never get sober. But there are groups, and Ron and I are very fortunate to belong to one of them, that are much more open and loving and accepting. And we've seen some wonderful success stories with people who have come to feel comfortable in our group. So that's just a plug for, you might get your feelings hurt a couple of times, but you might find the group that just hits it on the nose for you.
I'm so glad you shared that, David, because it's so true. I've had patients who I've recommended to go to meetings, and they went to one and they didn't like the group. They weren't open to either their background or them being on methadone. But what I always tell them is, don't stop there. Every group is so different, and you'll find your people. And so I really appreciate you making that known.
We often say we are not Wellies Anonymous. So we're not well.
Thank you so much. This has been an amazing discussion thus far. I want to go around and ask if anybody has any comments to add or to address any of David's concerns.
I just wanted to do a quick plug for Sonia. Also had a comment about disulfiram antabuse, which also might be an option for this patient to help with their alcohol use. And I worked in a methadone clinic where they could dose your antabuse with your methadone. And so if people commit to doing that, that might be an option for them. As most people are aware, disulfiram, if you have a return to use and drink alcohol while on disulfiram, you're going to get very sick. So the contraindications to using that are typically like anyone with serious heart disease or anyone who wouldn't be able to handle physiologically feeling really ill with alcohol. But otherwise, I've seen one or two patients that do well on disulfiram. It's not one we normally go to right away because oftentimes it's not the direction that patients want to go with their recovery. However, it is an option. I just wanted to make sure that also was known, that you can even dose it in methadone clinics potentially.
Thank you so much, Dr. Christian. In the interest of time, I will request you to please quickly summarize the case with some key recommendations.
Sure. So we had a 32-year-old male with opioid use disorder on methadone, as well as alcohol use disorder. Recently had a return to use of alcohol, continues to be on methadone. having difficulty accessing treatment for his alcohol use disorder, running into barriers and for inpatient detox. And I think some of the takeaways here is that our system is broken and we need to continue to advocate that patients who are on medications for opioid use disorder should be able to get access to care anywhere. So continue to advocate. Also for patients who are running into these barriers in the short term, you could consider a transition from methadone to buprenorphine if that opens up more doors for them. Or you could consider starting patients on a medication for alcohol use disorder after they detox from alcohol. So you could consider an outpatient detox, send them to Dr. Hampshire, and you could consider starting them on medications such as a camprosate or gabapentin, or even potentially dosing disulfiram at their methadone clinic.
Thank you so much. And thank you all for joining today's ECHO session. As a reminder, to earn C credits, please text the activity code 1009-5083 to 844-502-1338 by midnight tonight. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bvaltx@ythska.edu. Please remember, we do not have a session in December. We look forward to seeing you at our next session, our next shout session on Thursday, January 18th. In the meanwhile, please feel free to join us at our other sessions happening later this month, as well as the ones happening in December, which will be harm reduction, public safety, and the TextRx sessions. And you have a wonderful rest of your day. Thank you. Bye-bye.